Jeremy Jędrzejkowski, welcome to Rzeczpospolita TV studio at Economic Forum in Karpacz. Oncology remains one of the most challenging areas in contemporary healthcare. Although almost every year we can see huge progress in various therapies, still we need to do better to help patients. What's more, the new technologies and new solutions are not being implemented fast enough. What can be done about it? What are the recommendations? I'll ask my guests, experts in this area. Let me welcome Professor Jacek Jassem, President of the Polish Cancer League Medical University of Gdańsk. Hello.
Hello.
And Thomas Hofmarcher, Scientific Director, Swedish Institute of Health Economics. Hello.
Hello.
Mr. Professor, Polish society and healthcare system are facing an increasing burden of oncological diseases. Lung cancer remains the primary cause for cancer-related death among men and women. Lung cancer incidence is growing in population of women. Why is it so?
Well, this is a very good question. This is not only a Polish, I would say, finding, but it is also the case for many other European countries. Generally, in Poland, the incidence of smoking incidence among men dropped by 50% within the last decades, whereas among women, it was on the plateau or even slowly increasing. For many years, tobacco companies promoted tobacco among women with slim cigarettes, pinky cigarettes, something that is less harmful, which is very attractive, which is, I would say, a symbol of sex and things like that. And many of these campaigns resulted in increasing rate of smoking among women. Many women considered it as a kind of independence or equality or being adult. Of course, we have to do a lot to change this attitude, but it will take years. It is also another problem. Since the number of smokers generally in the society decreases, the proportion of lung cancers caused by non-smoking causes is increasing. And biologically, there are some data suggesting that women may be more susceptible to these agents. And there are also some hormonal factors. For example, estrogen is a well-known mitogen. We linked estrogen with breast cancer, but there are some data indicating that it may also be a mitogen for lung cancer.
And Mr. Hofmarcher, these days in September 2024, you have published a report called Cancer Dashboard for Poland, Lung Cancer. Please tell me, what is the scope of this material and what are the most important conclusions of the report?
Yes, so in this report, what we tried to do was to identify how good lung cancer care in Poland is. So we wanted to assess the performance of lung cancer care in Poland. And we looked at 7 different areas for lung cancer. And for each of these areas, we looked at different indicators to measure how good is lung cancer care and how does it compare to other Visegrad countries or other EU countries. We even looked at some inequalities within Poland, differences between the voivodeships. And we also looked at what are the aims actually in the national oncology strategy or in other strategies at the European level, at the global level for certain aspects that are related to lung cancer. And I mean, there are, in general, when we look at the findings, is that in many areas, Poland does not yet reach target values that are defined, or it tends to be just below the EU average. So there's still and need to improve, I think, the system as a whole. But if we look at different areas, Professor Jassem has just said it, smoking in the prevention area, smoking is still a major challenge and needs to be addressed. Another factor is air quality. Unfortunately, air quality is one of the worst in Poland, which contributes also to many lung cancers. But one particular thing that I would like to highlight that we show in the report for the very first time, thanks to a unique collaboration with the Polish National Cancer Registry and Professor Ditkowska, was that the survival rates for lung cancer, they have always been very low, no change. But now during the last few years, they have started to increase. And we have seen a similar development also in other countries, that in recent years, finally, the survival rates started to increase. But if you make the comparisons, the increase, the improvement in Poland is less high than in other countries. The question is why? And we believe when we look at the area of diagnosis and treatment, there are many different things where Poland is just making it very difficult for patients to receive high quality care. So one example is, for instance, during the past few years, we have seen this revolution in lung cancer treatment where we no longer treat patients only with chemotherapy, but we replace chemotherapy with immunotherapy for most patients, and for some patients also with targeted therapy. And the basic availability of these medicines has improved. The National Health Fund does pay for these medicines now, which is great news. But we see that these medicines are not reaching each and every patient that should receive them. So the uptake, the use of these medicines is not working as it should be. And one of the bottlenecks that we see is that biomarker testing is not working to the extent we want it to be in Poland. And for these new medicines to be given to new patients, you need to know if a patient is eligible. So it's this development towards a personalized treatment approach. But in order to personalize the treatment, we first need to do the testing to be able to select the right kind of patients, the right kind of treatment.
Mr. Professor, the report mentions the necessity of implementing well-structured patient pathways based on clear practice guidelines will further streamline diagnostics and improve outcomes. And how do these conclusions resonate with progress in implementing national cancer strategy for lung cancer? And how would you identify as the most important gaps and key focus areas to address with highest urgency and also on a long term?
This is a very important issue. Indeed, even though we develop recommendations for lung cancer diagnosis and treatment, I am personally involved in this process. I've been doing it for the last 20 years or so. They are not fully implemented in Poland because lung cancer diagnostics and therapy is very dispersed in Poland. There are hundreds of institutions dealing particularly with diagnosis of lung cancer. There are no competence centers like we have in breast cancer. We have breast units for breast cancer, around almost 60 breast units, where the diagnostic and therapeutic process is streamlined and is going according to the recommendations. We don't have this system for lung cancer. There have been debated for the last years, but it is not implemented. There is no one lung cancer unit in Poland. This has also some other consequences. If you don't have patient paths developed, you can't monitor the quality. The quality of diagnostics and therapy in lung cancer is not monitored. The whole process is very lengthy. It takes months from the first symptoms to the first diagnostic procedures and then to therapy. Another problem is what was mentioned previously is a poor uptake of modern therapies which are potentially available, and in fact they are available. But if we don't have these competence centers, many patients are not tested for example, for molecular changes or other molecular abnormalities allowing, for example, targeted therapy or immunotherapy. So in summary, there is a lot of to be changed in the system. There are no shortages in drug supply. There are no shortages in I would say, other access to other modalities like surgery or radiotherapy. The problem is that the system is insufficient.
As Mr. Hofmarcher mentioned before, the 5-year survival rate presented in the report indicates that the progress curve in the lung cancer treatment started to grow after innovative therapies and successively entered the game. So what does it mean in practice, in your opinion?
Well, indeed, by definition, if you have more effective therapies, you improve treatment results. In lung cancer, innovative therapies have been used mainly in advanced stage, but even in this advanced stage, we see an enormous increase of survival. For example, metastatic lung cancer, non-small lung cancer, treated with traditional methods like chemotherapy, the median survival was in the range of 8 to 12 months, whereas now with modern therapies, the median survival is 2, 3, or even more years. So it's an amazing progress. The same holds true for other methods. For example, stereotactic radiotherapy is another development. Many patients may be treated now with radical intent. Patients who are not amenable to surgery are treated very effectively with this modern radiotherapy. I can give more examples. Of course, all developments in therapy were translated into better survival, and I hope this process will continue.
And does it mean that we must invest in innovative therapies and the most efficient this is the most efficient investment in health?
The answer is very clear, of course.
And Mr. Hofmarcher, the lung cancer dashboard report is part of an international initiative aimed at facilitating the exchange of best practices in cancer care among European countries. And how is Polish healthcare system positioned versus another EU countries? And are they facing the same challenges, or there are some solutions that work much better in some countries, and we can follow that examples here in Polish context?
Yeah, so indeed, we're doing this sort of dashboard reports for several countries. And I mean, it is supposed to help countries understand what other countries are doing, because you don't always need to reinvent the wheel. And the good thing is that, you know, technology is progressing, innovation is happening for lung cancer with the treatments or with the medicines, or even with radiotherapy. The question is always, does it reach the patients? Do they have access? And I mean, what other countries have done, and what could also be a model for Poland is you know, and Professor Jassem has already said it, the standardization of the care pathway, try to make it more uniform across the country, try to cut down on the waiting times that patients are facing, from experiencing symptoms to going to diagnostics to starting the treatment. This is where you lose lots of patients on the way. So standardizing the care pathway should definitely be priority, and has helped other countries like Sweden, like Denmark, to improve the quality of care. That's that. I think the other good example, also already mentioned by Professor Jassem, is that for breast cancer, Poland already has a good model with these breast cancer units. If we are able to establish similar units for lung cancer, and I mean, it should be possible, because lung cancer affects so many patients. So, you know, I think it would be a good investment to have these lung cancer units working in a similar way as the breast cancer units. Then maybe this could be another way to improve the quality of care and to integrate the care services.
Thomas Hofmarcher and Professor Jacek Jassem, thank you very much for your views, your recommendations and all the remarks. And thank you for visiting studio of Rzeczpospolita TV. Thank you very much.
Thank you very much.